Good morning, everybody. I'll let everybody grab their cup of coffee or bagel or muffin or whatever your choice is, and we'll get started. Thanks for being here this morning. I'm Dr. Leslie McKinney. I'm the lead medical director for primary care at Blue Cross North Carolina, and we're really delighted to have everybody here today to really hear this important, timely discussion. I see lots of familiar faces out in the room, so it's great to have folks here. And everybody's here for a treat. We're really, really fortunate to have Dr. Toyin Ajayi here today from City Block Health. She is their chief health officer, and she's just delightful, so this will be a really, really special morning. Toyin is one of the co-founders of City Block, which is really the first technology-driven primary care provider, which is focused on serving communities with both complex health and social needs. And we've been working with Toyin and the City Block team at Blue Cross for over a year to have them bring this special model really to focus on the Medicare Advantage members as well as Medicaid populations here in the state. And bringing better care to patients and to neighborhoods is really not a job for Toyin. As I've gotten to know her, this is her mission, this is her passion, and you will feel that from the minute she walks on the stage. She is a board-certified family medicine physician, and she worked to launch City Block to really do something radically different, which is to focus on community health and the underserved population through an integrated primary care model. So I'm really excited for you to hear about that today. Toyin previously served as Chief Medical Officer for the Commonwealth Care Alliance, which is a nationally recognized integrated health plan and care delivery system in Boston. She earned her undergraduate degree from Stanford. She has a Master's of Philosophy from the University of Cambridge and her medical degree with distinction in clinical practice from King's College, London School of Medicine. So she's been around the block a few times. And on a personal note, it's been such a gift to work with Toyin and really the whole City Block team over the last year. We're so lucky to have her leadership here in North Carolina. So let's give a warm welcome to Toyin.
Thank you so much. Thanks for that wonderful introduction. It's been such a privilege to get to work with you all and to start to learn about North Carolina and start to think about how our model can ideally have a real impact on the populations that you all are so committed to serving. So I'm going to talk not for the full time. I'm going to try to leave some time for questions and conversation, but it really is an honor to be here. So I want to start, as I typically do, with just a reflection on a patient story, a reflection on the types of folks that I am deeply passionate about serving. This is a woman we'll call Patty. She was someone who I actually was involved in care with several years ago now, but her story is very typical of, I think, a lot of folks that we encounter in the healthcare system today. She was 44 years old at the time. She had on her medical and problem list asthma, polysubstance use disorder, PTSD, anxiety, and she was hospitalized probably about 4 times a month with asthma exacerbations. Sometimes when she went into the emergency room, there was evidence that she'd been using cocaine and other drugs. Sometimes it was simply that she'd gotten into such terrible respiratory failure that, that she was requiring acute care. Almost always she needed intubation, so she needed a breathing tube placed in her to help her breathe. She always ended up in the intensive care unit. And I would say 9 times out of 10, she would wake up and discharge herself against medical advice. And this is a very common thing. It's more prevalent amongst lower socioeconomic status individuals. It's more common amongst people who are Medicaid or uninsured. And we see it more commonly amongst folks who are racial and ethnic minority populations. And she was all of those things. And so she would leave the emergency room, and the doctors and nurses would throw their arms up in dismay. She's not doing what we told her to do. And without fail, she'd be back in a few weeks' time. What happened for Patty is that one time, her final hospitalization, she had been without oxygen for so long that she was unable to regain brain function. And she finally passed away in the intensive care unit at 44, leaving 2 small children. And I was, as a physician, as part of the care team, so disturbed by what had happened that I spent many, many hours combing through her chart to really try to understand what went on. And what you see is exactly as I described. This is a person who went to the emergency room almost exclusively for her care. She had a primary care doctor, but she had actually not seen that person for 4 or 5 years. When she was discharged, she was almost always discharged per hospital protocol with a follow-up appointment. Almost always it was with someone she'd never met before. She had been outreached by 3 or 4 different case managers, one from the hospital who would call to make sure she'd gotten her medications. Almost always she would hang up on them or not have a meaningful interaction. She was being followed by the pharmacist to try to make sure that her meds were getting done. And she was being followed by the health plan case managers who were located somewhere else and calling her up in the evenings. And I just imagine what her life looked like. You can imagine coming home from the hospital with 2 small children, one of whom, as you read through the charts, was struggling in school, both of whom had asthma themselves. You can imagine what it was like kind of making dinner and figuring out how to get these folks, her family, what they needed, and getting a phone call from a random person saying, hey, did you do this thing? Are you going to go to this appointment? Why didn't you take your medicines? Why did you leave the hospital? What does that feel like for her? As we started to comb through even more in her charts, I found buried in a social work note. One time, she'd finally seen somebody for behavioral health, and the social worker had elicited in this beautifully documented, very, very long note the fact that, that Patty had witnessed her brother actually being killed when she was young, and she had panic attacks and anxiety, and she had trouble sleeping, and that she continued to feel the repercussions of that. And sometimes she would take substances to try to alleviate her anxiety and distress around that. That she had no psychiatrist, she had not been formally treated by a behavioral health clinician, and the pearl in this story is that she had a cat to whom she was allergic, but she would bring into her bed at night for comfort. And that cat was triggering her asthma, which was triggering her hospitalizations. And nobody had really put those pieces together for her. It was not clear who the owner of the relationship was for her, and her data was scattered throughout. And as I said, she left and was not, and the cycle of poverty and poor health continues to repeat for her family. So what are we solving for when we talk about folks like Patty? What are we solving for when we think about the work that I'm doing? We're solving for a number of things. Often the first thing you see, the headline, is we're solving for spending. The US spends more in healthcare than other industrialized countries. Our costs of care are high and rising. We spend more than 20% of GDP. This continues to increase. We continue, 10 years ago, people were like, this is unsustainable. It's now higher than it was 10 years ago. We have a more than 2-fold difference in healthcare spending between the US and other similar industrialized countries. And there's no evidence that this is slowing or reversing. I care about this, but not that much. The other thing we know is that spending impacts our local budgets. Well, this I care about. This matters for people like Patty. So this is a chart. I haven't seen another state produce a graph like this. I'm not sure how well you can see it, but this essentially shows trends in state budget, in Massachusetts state budget coverage for health and other priorities over almost a 15-year time period. And what you see is that healthcare goes up meaningfully, and that education, public health, infrastructure, and housing goes down, right? So our spend on the things that would actually keep us healthier goes down even as we spend more money on healthcare, on emergency rooms, on ambulance rides, on the reactive things that are a consequence of, as I would argue, broken infrastructure around the things that would be preventative and keep people out of the hospital. I really, really care about this next one, though. It's about household spending. So now we think about the individuals. Think about people like Patty. Think about us all in this room. Think about our colleagues, perhaps who have smaller paychecks at the end of the month than we do. What we know is that middle class and lower income families spending on healthcare has increased by 25% over the last decade. And that this, again, comes at the expense of basic needs. This is zero sum for individuals. What we're finding more and more, and finally we're actually starting to survey this, is that this happens even amongst people who have health insurance. So our Medicare Advantage, our seniors, are paying more money for healthcare than they ever have, and this is continuing to grow. So we have a problem that flows from the top line GDP measure all the way down to individuals' day-to-day choices about what they eat, how they clothe themselves, where they go every day, how they care for their children and for their families and their loved ones. And as everything when we talk about this, we see that our marginalized communities, our seniors, our lower income individuals, our racial and ethnic minorities, our colleagues and family members who live in rural parts of the country are disproportionately impacted by all of this. So we're spending a bunch of money. What are we getting from it? I think we all know this. This is not a shocking headline. Much of this spend seems to be wasteful. We have really high rates of medical errors. We have really high rates of non-guideline driven care. We have really high rates of overuse and overtreatment. And we don't have a longer life expectancy in this country than developed countries, other developed countries that spend less money. We don't have higher functional status, lower morbidity. We have certainly more inequitable outcomes. Our households and our individuals are not able to invest in better futures for the next generation when the #1 reason for personal bankruptcy in this country is healthcare bills. How in the world can we start to build back all the things that are taken from people? And then equity. These pervasive disparities in health outcomes are just such an indictment on our social and healthcare infrastructure. This is data from North Carolina. You all publish, your Department of Health and Human Services publishes annually disparities data. Probably can't see this very well, but what I will tell you is that infant mortality amongst African American children, newborns, and infants in this state is about 4-fold that for whites, and that is a persistent trend. We see this everywhere across this country. It says something about how we are investing in health and social infrastructures. And then I talk a lot about trust because I think it is so important. At the same time, we find that our communities, the people that we serve, I'm a primary care doctor, these are my constituents, they don't believe we can be trusted. A study that was published in the New England Journal of Medicine in 2014 actually surveyed individuals across, it was multiple countries actually, and they found that only half of low-income Americans believe that their doctors can be trusted. This is more disproportionate amongst people in poor health. So 35% of low-income folks in poor health have felt disrespected by a healthcare provider. That's such a potent word, disrespected. How do you trust somebody who makes you feel disrespected? 40% of people believe that the healthcare system prioritizes keeping costs down over doing what is best for their health. Sorry. You guys can hear me, right? Sorry. And when you look at kind of consumer survey indices, and so this is national surveys again of people's satisfaction with industries, we rank lower than car salesmen in consumer satisfaction. Ambulatory care in hospitals. Insurance companies are way, way down there. No surprise to anyone. And then I added this because I think that there's something here. Some of my colleagues who really focus on primary care, in particular primary care physicians, have started talking about the term moral injury. This is a way to contextualize what we see in terms of burnout and dissatisfaction and depression amongst clinicians, particularly primary care clinicians, that is disproportionate to just about anything you can explain in terms of their work and conditions. And the idea here is that folks feel worse in a moral injury way when they are doing work that feels futile in some way. If you are constantly watching someone like Patty come in and out of your hospital, come in and out of your clinic, or no-show to your clinic, knowing that you don't have the tools to impact them, what does that do to you in terms of your sense of well-being and your sense of passion for the work that you do? And what we find is that this is an epidemic also, and is something that I think is all interwoven in the way that we have delivered our healthcare system. So why is this happening? What drives spending? What drives value? How do we ensure better and more equitable outcomes for the populations that we're committed to serving? Well, first, what drives spending? Again, this is something that's probably quite familiar to you all, but it continues to jar me. In every population, no matter how you slice it, almost to the percentage point, what we find is that the top 5% of a population drives about half of the spend in a population. There is a long tail of individuals who have very, very, very high healthcare costs in every system. Cut it by line of business, so for folks who are commercially insured, folks who are Medicare Advantage, folks who are Medicaid, cut it by age, by geography. This is almost always consistent. And as you go further down the stack, top 10%, it's about 2/3 of spending. So we know that it's concentrated in a small proportion of people. These folks tend to be sicker and frailer, no surprise. So these are folks with 3 or more chronic diseases with functional limitations, high need, high utilization, and again, you start to see that really correlate. And the numbers get staggering at the top end here. They're also more likely to be low income, to be disabled, and or to belong to racial and ethnic minority groups. So these things start to coalesce. This is what drives spend in our system. These are the individuals who have the highest cost. What drives disparities around that? Well, here I hypothesize there's a few things, and probably you can start to get a sense for where my thrust is. The first is this. This is data from the U.S. Census Bureau. So the Gini index is a well-known measure of income inequality, essentially, disparities. And what we found in this country is that this has been rising dramatically over the last few decades. So we have a system of capitalism that actually intentionally increases the wealth of the top 1% at the expense of the majority. And if you can tie that to what I showed you earlier about the share of our income that we spend on healthcare and the share that is not left to spend on food, education, transportation, social services, this is all tied together. The folks who struggle with lower resources are then in a cycle that exacerbates itself over and over and over again. We also know that we have a really big problem with bias, stigma, and discrimination, with racial bias, with stigma and discrimination against people with mental health needs, with substance use needs, people who live in rural areas, people who sound or look differently than the majority, than the dominant, and that this impacts health outcomes. This is one of many now quite seminal studies that demonstrates that a person of color accessing acute health services for the same clinical presentation is less likely to get treated for pain appropriately. There was a landmark study in probably the 1980s now that surveyed hundreds of cardiologists with standardized clinical scenarios, was published in the New England Journal of Medicine, and found that if you changed one thing about the clinical scenario, you substituted African American for Caucasian, a person who was presenting with classic symptoms of a heart attack was significantly less likely to get aggressive treatment for that heart attack. So there is something here too. And this is structural, and this is a problem. When you look at the population of folks that I particularly spend a lot of time caring for, people with serious mental illness, we know that the folks with mental illnesses have on average a reduced life expectancy of somewhere between 7 and 24 years. That is a quarter of a decade disparity in life expectancy. And when you adjust for clinical comorbidities, you adjust for coronary artery disease, you adjust for smoking, you adjust for diabetes, there is something else here that we cannot explain by the clinical presentation alone. And when I talk to my patients, what they say is, I go to the hospital because I have a sore throat, or because my arm hurts, or because I have palpitations, and all they see is that I have bipolar. All they see is that I have schizophrenia. And they don't believe me. So I know this happens, we know this happens, right? And we can see it in the data, and we can see it in those disparities and outcomes that are so pervasive across our population. And then I think there's something on us in healthcare that is about our, I think, misguided notion about what equity actually is. And so when I was training, I was taught that everybody gets the same thing. That's what makes us virtuous. Everybody gets the same. I don't discriminate. I give everybody the same thing. So if I have a patient like Patty, the woman I described earlier, who is a single mom in low-income housing with significant anxiety and trauma, trying to provide care for her family the best she can with chronic diseases, and she needs to see a primary care doctor, I tell her to call the front desk, make an appointment. We'll give her an appointment, first come, first serve, and she gets there, and she waits, and the first person who can take care of her provides care. She gets the 10-minute visit that everybody else gets. When she's done, she gets a prescription, and I have done my duty. And better yet, if I provide evidence-based guidelines to her, which recommends 5, 10, 15 medications, and I hand that off to her, regardless of what her copay looks like, regardless of whether she has transportation to get there, I am doing my best. That's actually not equity. That's a problem, because she needed more than that. She needs a lot more than the person I see in clinic who has a job, who has resources, who speaks English as a first language, who can get to the clinic whenever they need to, who can use their smartphone to order their medications to pick up from the pharmacy on their way home from work. She needs a heck of a lot more than that person. And my sense that I am doing right by my patient by providing everybody the same actually gets us to a position where we have not changed our disparities. And that's really, really hard, I think, for healthcare providers and systems to think about, because what it means is that we have to segment. We have to know our populations. We have to knowingly introduce different levels of care based on individuals' needs. That is the right thing to do. And once we learn to do that, we can start to chip away at some of these disparities. And then finally, we've been really slow in healthcare to understand and engage around social drivers. So what we know is that non-medical factors contribute more significantly to a person's well-being and their outcomes and their genome and their disease burden and the quality of care they receive. But we've not really thought about that in healthcare. When I was a resident, I had a fellow who I worked with in the intensive care unit. He used to say, oh my God, I've got to do all this beyond healthcare stuff, right? Whenever we had to do a family meeting, which was frequently for someone who was approaching end of life and they were complicated, they would say, oh my God, this is beyond medicine. This is not what I went to school for. This is not my job. How can it possibly be my job to figure out how this person's gonna get their meds? How can it possibly be my job to stay late to talk to a family member who's working 2 jobs and can only get over to talk to us at 8 o'clock or 9 o'clock at night? It is our jobs. We haven't thought of it that way. We haven't resourced it that way. That is why the social worker note for Patty was buried somewhere. That's why in every clinic that I worked at as a trainee, there was one social worker at most. They had like the ugliest, darkest office. It was in a closet somewhere. Their tools were not built for them. If they could document in the EHR, it was always somewhere else. It was locked. You couldn't access their details of their notes. Like, we didn't think about this stuff. This was an afterthought. We patted ourselves on the back when we had a food pantry nearby that we could refer people to. We tracked the heck out of our referrals to try to make sure that we closed the loop when we were trying to get, somebody who needed a knee surgery to get to the orthopedic surgeon at our hospital. Everybody really wanted to make sure we got that referral done. But nobody asked us what happened to the people we handed prescriptions to or recommendations to for things that did not include high-cost medical procedures. I can vouch that very few health system leaders know, as an example, what proportion of people are seen in their clinics who have a domestic violence situation, who are handed the requisite list of resources, actually ever access them. Do we track that? Nobody cares. We haven't ever really thought about how important this stuff is. And then what drives distrust? Well, here I don't know. I mean, we don't have a lot of studies. Nobody measures this. But I have some hypotheses. I was just poking around a couple nights ago, and this is an infographic published by the National Institute for Health, the National Institute on Aging, as a tip sheet for seniors to talk with their doctors. The first thing it says is you have 18 seconds before someone will interrupt you. Why do we tell our seniors that they've got to be prepared to tell their lives stories to their doctors in 18 seconds? And we accept that as fact. How is someone going to know me well enough to gain my trust? We know this to be true. We know that our clinicians spend more time looking at computer screens than they do at patients and touching them and talking to them and building relationships with them. We know that the likelihood of a consistent primary care relationship for low-income communities in particular is very low. And I mean, like, did you see the same doctor more than once for over a period of time? Very low rates of continuity of care. We've structurally not set ourselves up to even begin to build a trusted relationship. And then we're fragmented. I talked about loop closure. To half of medical specialty referrals for low-income older adults never get completed. So we say we want one thing, we never follow through with it. You really need this test, we never follow through on it. You need a referral, we never follow through on it. Come see us, we never really follow through on it. We had a patient come by actually recently asking whether or not we would fine her for missing an appointment. It's pretty common practice actually for doctors to fine and penalize and fire patients for not doing what we tell them to do. It's very hard to imagine a trusted relationship anywhere else in your life where someone holds that much power over you and is not afraid to wield it in ways that feel punitive at your times of need. It's not uncommon for us to turn people away if they're actively substance using from healthcare resources. How do you build trust there? What other relationship that in my life would sustain that sort of abuse? And yet we deliver it to people so frequently in healthcare. And there are so many ways. We talk about surprise billing from the payer side. Imagine what it feels like to go anywhere else, buy a shirt from a store, take it home, nobody told you how much it was going to cost, and then you get a massive bill later. And you say, actually, I don't really want this shirt anymore. You can't return it. How do you build trust? Would I go back? Probably not. I'm not interested in that. There are so many ways in which we erode that level of trust with folks. And we have an opportunity and an imperative to transform. And this is where I continue to feel like we're sitting here in a moment in time that is so powerful that we have to take advantage of. None of the things that I just showed you were sustainable. We cannot sustain thriving communities with costs of care going through the roof, with quality remaining low, with disparities continuing to rise, with people turning away from us, going to Dr. Google and all sorts of alternatives. We've got to figure out a way to engage and build trust and build relationships and deliver high-value care to folks. And I believe it's possible. I believe you can meet people with the right care at the right time. I believe it's possible to do this in a sustainable economic model, and I think we have an opportunity with value-based care on the rise to really think about what it looks like to do this at scale. And we have models to demonstrate and to follow. I'll talk a little bit in this section about kind of how we think about this at City Block. By no means is this the only way to do this, but I think that we have started to take advantage of these opportunities and more importantly, a real passion and a commitment to changing the paradigm, not just for the 1%, not just in a small pocket, in a silo, not just in the Northeast, as an example, where I've trained, where we have expanded Medicaid coverage and have a lot of social services. We're committed to the idea that this should be the norm for everyone, as opposed to the exception to the rule. And in order to do that, you have to be prepared to transform. So our model consists of 3 core components, which I'll talk about more in detail. The first is physical space, neighborhood hubs that feel more like community centers and social spaces than they do clinics. The idea that if I'm going to ask Patty, as an example, as a person with lots of things going on, to take time out of her day, to pay for childcare, to pay for transportation, to come to see us, we should honor that with an experience that leaves her feeling valued, that leaves her feeling like she achieved something, that she derived value from that, and that leaves her wanting to come back. And so what does that mean? It means a few things. First, spaces need to look and feel good. They need to feel like they were designed for the folks who are actually using them. It matters how it gets packaged. It matters what it looks like. It matters that there's art on the walls, that the bathrooms are clean. It matters that we dignify the folks that we care for with a space that is respectful and honoring of their time and of their attention. It also matters that we're able to deliver things that are helpful today. So if I have somebody with high blood pressure who's struggling to get their blood pressure under control, they probably don't feel that bad on a day-to-day basis. They're much more concerned about the fact that they got an eviction notice, as an example, or that they are struggling to figure out where they're going to eat at the end of the month. Well, we can help do things about that. Why wouldn't we? Even as we work on the path to helping them achieve their clinical goals, if I can solve a problem for you today, I should do that. And more often than not, the problems I can solve today are cheaper than providing reactive healthcare in the hospital and are more likely to build that level of engagement and trust. So what does that mean? It means that we're asking about things that are important to people and that we're solving some needs on a day-to-day basis. In Brooklyn, New York, where our first hub was, we asked our community members what they needed and wanted from us, and it was Wi-Fi and a place to charge your phone and like temperature control. So if you're traveling 2 hours on a train and a bus to get from the Queens to South Brooklyn to do your job as a janitor, being able to stop someplace, put your feet up, have a snack, maybe a cup of coffee, cool off in the summer, warm up in the winter, plug your phone in because you're out of juice, log on to Wi-Fi, that's huge. I just solved a problem for you. And while we're at it, let's work on your anxiety and your depression and your diabetes. But let me do that. And why wouldn't we? We can. And in here, here in North Carolina, we hear a lot about, in some communities, laundry services for our folks who are struggling with homelessness. Big deal. Small thing. A place to shower. These are the sorts of needs that we hear from our communities that we think we ought to be able to solve for. They're not hard, but they're important. The second part of the model is a personalized care team. And so really taking the notion that we are providing equitable, we're pushing towards equity, which means that everybody needs something slightly different, and we can modularize our care teams to solve for that. A person like Patty needed a behavioral health specialist on her team so badly. She needed one. She didn't need to wait in line for the referral from the social worker to get to the this, to the that. She may have needed one more than she needed a primary care doctor. We should be able to solve for that. We can add that person to her care team and make sure that they're there to meet them where they're at, meet her where she's at. And the ability of those teams to go to people's homes, to meet people on their own terms, is so incredibly powerful. I spent most of my sort of early clinical career doing almost exclusively home visits. I had a panel of folks, of women who were marginally housed and homeless. So I saw people in shelters. I would see people in community gardens. And I would see them in their homes. And the act of going to a person's home who is struggling, saying, actually, you know what? I value your time. I value your comfort. When I look at what it takes for so many patients to make it to the clinic, and I ask, could we deploy a resource to their home more effectively with higher fidelity and get the same outcome? The answer is absolutely, undoubtedly yes. Like, why did we think we needed to build these huge bastions to our sort of medical supremacy, if you will, and force people to come to us when we can go to them? And we should. And so when I go into a home visit for someone and I sort of go through the ritual of that, think about all the things that are different. I take time out of my schedule. I schedule an appointment when I know they're going to be there. So it's on their terms. It's none of this, I'm going to book you an appointment, I'm going to tell you about it in the mail. It's like, no, I'm going to confirm with you because I really want to make sure you're there. I go to their home, I knock on the door. I'm a little anxious. I've never been inside. It's an unfamiliar territory to me. Think about that. When a patient comes to see me in my clinic, they have that same reaction. Their heart rate goes up a little bit. They're a little uncomfortable. They don't know what they're going to encounter. Now I'm taking on that burden of that sort of psychic distress, and I'm changing the power dynamic. I don't have a white coat. I don't have all the things I know and need. I don't feel comfortable or familiar, but they do. I wait for them to come. They let me in. I sit where they tell me to sit. They sit in their comfy armchair. I sit on the chair that's left over. Wow, what a power dynamic shift, right? And how does that feel? Again, these are really, really important things. And when I'm there, I ask their permission to open the fridge. I can see what's inside. I can open out their medication cabinet and see what they're taking. I can see who's around the home. I know that if I'm taking care of a senior and they need food and I provide a meal to them, that they're going to feed their grandkid. They're not going to eat that themselves, and that we should think about that as we think about how we deliver social interventions on a household level. And I get to sit with them and look at them, look in their eyes, actually understand how they live, show them that I care about them. It is such a powerful thing that we can do in healthcare that we do not do because we prioritize so many other things about the way our system runs. We do this at scale at CityBlock. We use community health partners as a key part of our care model. These are folks who are not clinically licensed, who are hired from the communities we serve. They are an exceptional professional workforce. These are people who are tenacious, unbelievable at multitasking. They're kind, they're empathic, they have off-the-charts EQ. They can listen for all the things that are unsaid and build and sustain meaningful, trusted relationships. And they spend all their time in the community meeting people and engaging with them and helping to build that bridge back to the clinical world where people continue to have a little bit of mistrust of healthcare providers. We use them to extend us in really powerful ways. And then finally, technology. So thinking about the tools that we've built in healthcare and who they serve and what they serve, I think led us to really believe that there's an opportunity to build technology that is different for this purpose. The things I need and the things my patients need are not fancy gadgets. They're not, apps that they have to sign on to in the App Store and do two-factor authentication and use all their data for. It's not that. They need to not have to tell their story 54,000 times everywhere they go. They need for people, when they encounter the health system, to know them and know what's important for them. They need a place to go where we can connect all of the dots around their care, not where the social work note is buried someplace where someone would have to go hunt for it, but where it is surfaced right at the top and allows us as a team to deliver what they need. People love to SMS, to text. We've overlooked that as a really important modality historically in healthcare, I think largely through concerns around how we manage through HIPAA. But that's what lawyers are for. So we should use them to do that. And it's possible to have meaningful relationships through text. You can do a ton of things through text messaging as a way to keep people connected, and we've been able to build that through as well. So as a concept, I think that there are some really important design concepts for us. I think the first thing that really drove the way that we thought about City Block is that we want to design for people living in underserved communities who have complex health and social needs. We do not believe that innovation trickles down passively. When I look at how my day-to-day life has changed in the last 10 years just because of my smartphone, and all the ways in which I access the world differently as a result of that, and all the ways in which many of my patients' lives are effectively unchanged through technology, I think that there's a huge disparity here in the way that innovation impacts the folks who really need it, because we don't design and build technology for them as the primary user. And so we have to do that. So we lean really heavily on research in communities with our members, with our care team members, to gather data, to learn, to develop tools that promote empathy, and to ensure that we're building for our end user intentionally. And if it helps to benefit the 1%, that's great, but that's not why we're here. We're here really and truly to understand how we crack this really hard problem. Reorienting the care team. I talked about this a little bit in terms of the role of the community health partner. This is really potent, I think, because I think a big portion of why we see so much fragmentation of communication in healthcare, and why we also see so much alienation of our patients and our members. The question about why Patty left against medical advice, left the hospital every time. And why people's response was like hands thrown up, I'm so frustrated with her, as opposed to trying to understand why. I bet that if we had somebody who met her on her own terms, who wasn't judging her, who wasn't saying, why didn't you do this or do that, or why didn't you take your meds, or why didn't you follow up, but who said, just what's going on for you? I know it's hard, tell me more about it. In a non-hierarchical way, I bet we would have figured it out. I bet there's an answer there. And it might have been something as simple as, I've got 2 kids at home, and I've got nobody to look after them, right? It's stuff like that. But it pervades all throughout our healthcare system. If you think about where the power lies in healthcare, it is doctors at the top, and everybody else by level of, usually it's by licensure, layered on, right? And so the person who probably knew what was going on for Patty, it might have been the person at the front desk in the unit and the emergency room, or in the intensive care unit. It might have been the medical assistant in her primary care doctor's appointment offices, who may see her more frequently than anybody else does. It might have been the concierge in her apartment building. I don't know who that person is, but I can guarantee you that if they put their hand up to say, I know something that could be helpful, no one would have listened to them in traditional healthcare. Because we're not conditioned to do that. So what happens if you flip the power hierarchy? If you say, we are infusing within the care team power amongst the people who frequently would not have been listened to, and we're asking them to carry the water for us. And so what that means for me in my practice is that the community health partner on my team, with a member I'm working with, tells me what to do. They don't care that I went to medical school and blah, 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 blah. They are responsible for ensuring that everybody does their job for this member. And if I'm dropping the ball, they're going to tell me very clearly, and I'm going to listen to them because they're in charge. And that is really, really, really radically different in healthcare, and I think it's really important. We talked about technology and the ways that in which we build technology. We didn't build fancy apps. That was not the first thing we did. We built a tool that allows us to coordinate, communicate, and collaborate, to fully understand what was going on for somebody, to message them within the app, to deliver information across a team in a democratized way, to build in decision support so we can do the things that we talked about. We can stratify. We can identify who needs what and deliver that to them in the right dose at the right time. That's what we built. And then we start to layer on more and more and more elements to the technology in response to what our communities and our members and our care teams need. And finally, thinking about design as a core product value. And I think as prior to finding myself in this weird space of co-founding a company that is deeply, deeply, deeply rooted in technology, I had basically no experience with technology except as a user/victim in healthcare. And I think my sort of ingoing sort of aversion to technology was driven by the experience of going through, I don't know how many like EMR rollouts. You get hives thinking about how poorly designed these things are, and then we get mad about the number of clicks you need to do what. What if you started from the ground up and said, all right, let's like enable a user experience? You think about all of the other technology tools I use in my day-to-day life. I would never tolerate such abrasion. If Google Maps was like clunky as the EHR is, I would never use it. But we never thought about clinicians and other members of the care team as users, as consumers, as discerning. We didn't ever have a choice. It was foisted on us. And so what if we design with those same elements? We take the same people who built delightful products that we use in all other elements of our lives and put them to this task. And there is a way to reconcile regulatory needs and process needs with ease of use and delight of the user. And doesn't that allow us to then collect more data and do more things more effectively? I talked a lot about already sort of decision support and care planning. And then knitting together these social factors that impact health. And this is a really key area for us. We are really nascent in healthcare in our understanding about how social needs and social factors impact health outcomes in a way that I would describe as being dose dependent. So we have a very like conceptual understanding of this. We know conceptually, organically, emotionally that it is, as an example, it would be very hard for somebody who has end-stage kidney disease and needs dialysis 3 times a week to effectively engage with dialysis if they are homeless and are food insecure. We know that. Great. Is the solution to provide that person with a house? Is the solution to feed them 3 times a week? It might be. It might not be. We don't know. We don't yet understand how to dose our interventions on social needs as a healthcare entity, from the perspective of healthcare. How do we fund this? For whom? In what dose? Because there's many different ways you can provide food to somebody. You can cook it, bring it over. You can help sign them up for a benefit. You can get them on SNAP. You can teach their loved one to shop and cook. You can help them retain more budget and be able to buy food for themselves. There's lots of different ways to do this. These all have different costs and different outcomes. They should be applied differently. And so what we're starting to do is to say, let's take the best available literature and research around interventions for social factors, and let's start to test them out and actually start to really understand how we might dose social interventions based on what people need. The flip side that's not on this chart but I think is really important is also understanding how social protective factors play into people's outcomes. And so we have, we as a field tend to approach social determinants as being deterministic and being negative in many ways. We're talking about bad outcomes that are predicated on your social context. The flip side is also true. And I learned this very, very much from taking care of older women who are homeless and marginally housed. They are the most resilient people you will ever meet. If you are alive at 80 years old and you've been homeless for the better part of your adult life, there is something magic about you. And we need to understand that as much as we understand the things that cause someone like Patty to die at 44. Those two things have to exist as we think about this work, because we can't go around saying you live in this zip code, therefore. We've got to start to understand where people have resiliency, how we can build that forward, how we can help people recover from trauma, how we can build protective factors around individuals and communities. That ultimately is the way to start to really create transformative community change. So for people like Patty, and I go back to her and I go back to people like her that I've cared for and lost in many circumstances in my career, what would this have felt like for her? To have, instead of 3 caseworkers she'd never met calling her at random times, telling her things she ought to do, instead of having the doctors and nurses and other well-meaning, well-intentioned professionals she encountered in the hospital throwing their arms up saying, you keep leaving against medical advice, what can we do for you here? Instead of that, what if she had somebody who looked like her, sounded like her, who met her at home on a Tuesday afternoon and said, what's going on for you, really? Tell me about your brother. Tell me about where you sleep at night. Tell me about what keeps you up at night. Tell me about how we can help and be there for you. What if that person started to unlock a team that was dedicated to her? If they recognized through their own instincts and education, but also through decision support, that she needed a therapist to her house, Not tomorrow, not 6 weeks from now, not when she can make the appointment, but like now, to her house, who could sit with her and start to unpack all of the layers of complexity. What if she had a clinical team that was consistent? People who knew her, who she knew and trusted, who she could call when she started to feel wheezy before she ended up in the emergency room? What if she had folks who understood that being in a hospital meant that somebody was not looking after her kids and had created a plan with her so that we could escalate and intervene at a time when she needed us the most? What if we were thinking about housing and transportation and food and connectivity and social isolation, all as determinants of her outcomes? Would things have been different for her? And most importantly, like, where would her kids be today? All of this hinges on building trust and trustworthy systems that are oriented towards the individuals and communities that we're serving. That's where we start. And that's the thing that gets me up every day. I sense that we share the same passion around that, but I do believe we can get there. So thank you, and happy to take questions.
Thank you. So I think we've seen just the healthcare industry and the provider space in general move increasingly towards consolidation and just getting bigger and bigger and more bloated. And a lot of times people see that as integration of care delivery. How can you reconcile that with this more localized and divisional model and having that represent integrated care delivery?
Yeah, no, that's a great question. I mean, we're in the buzzwords phase now of integration, and to your point, integration means very different things to very different people. I think that one way to pressure test this in one use case is to map patient journeys. We call them members at City Block, but map a journey. So does it matter to a patient in a community where we've just had a merger and a big integration of systems? Does it matter to their day-to-day, and how does it impact their day-to-day? And so if you think about somebody and actually map them through, what we should be asking our systems is, I actually don't care what your corporate structure is. I don't care who owns whom. If I walk into a clinic, a primary care clinic on a Wednesday morning, and I am struggling with my anxiety, what happens? Tell me what happens. Map out the flow of what happens. Where is that information housed? Who processes my referral? How quickly do I get seen? What happens if I also need to refill my asthma inhaler and I brought my 2-year-old along who's overdue on their immunization? Are you gonna tell me to go 4 different places? Are you gonna ask me the same story 3 different times? Or does it all happen for me now, here at once? And if we start to ask that question, then it starts to unpack a few of the layers. That's the one piece on the integration side. The other piece on the economics, though, is much more complicated. Because as we all know, certainly, and the literature supports, integration does not lower, consolidation does not lower costs. And so we have a bigger problem here to think about from a regulatory perspective about how we might want to think about approaching the cost side of things from the perspective of delivering value and from the perspective of the side I showed earlier about escalating costs and the impact they have on individuals on a day-to-day basis.
Thank you, Twain. That was wonderful. I think about what you described in terms of your training. And so looking at your staffing model coming in North Carolina and those you've brought on, how do you incorporate and train or retrain this care team to think differently as they've been doing it for so long?
Yeah, no, it's a great question. I think and I don't have a really, really good answer yet. We're still learning. I think the first thing is that this is an opt-in model. So it's not for everyone. And we're really rigorous in our interview process, particularly for clinicians, but for everyone across the board. If you make it through and you still want to come back, then you're probably one of us. So we're not yet at the point where we are starting to really think about massive scale on the provider recruitment side, where we're saying we're going to take people kicking and screaming and try to put them in this new model, which we have to get there, right? I do believe that in order for us to transform across the country, we're going to have to retrain ourselves as clinicians about how we approach our colleagues as well as our patients. And we're gonna have to shed ourselves of some of this power that we're so used to holding. But today, if you want to be part of this, it is because you feel in your bones that things need to be different. It is because you're not going to insist on wearing a white coat and being referred to as doctor yes, doctor no, doctor this, doctor may I, but that you are comfortable already and excited to embrace a world in which you get to work with people who are just incredibly talented as equals, working on the same path to improve outcomes for population. And so we're fortunate. We do a lot of training. And we have a robust orientation process that puts everybody together as an interdisciplinary team in a cohort. We talk about ourselves, our lives, our backgrounds. We talk about trauma-informed care. We talk about motivational interviewing. We get the same sort of core curriculum. And then we just bump people up against each other. And we let humans do the thing they do best, which is form connections, build relationships, build trust, communicate and collaborate around a shared goal. And people find joy in that work. So it starts to beget itself. But I think that there is a broader question about how we approach medical education, how we approach the sort of next wave of transformation of primary care, where we went from, the doctor in their office by themselves with the door closed, doing their thing all day, every day, to patient-centered medical home, where we kind of rearranged the deck chairs a little bit. We added a few more people to the mix, but the silos still sort of persisted, to this new world, which is, it's a team. We've got to work together. Everybody has a role to play. Nobody is more important than anyone else. And let's figure out what it takes to actually deliver care in that type of environment.
Kind of hit on what I was going to ask you, but just to dig a little bit more, to spin off of what Lori was sharing. So learning, connection, education, I'm really curious of your specific thoughts, if you're willing to share, on that power paradigm shift in medical school specifically.
Yeah. I mean, I don't have very deep thoughts on this, so I'm happy to share them, but I don't think they're going to be very helpful. I honestly don't know how to even tackle it. Like, I find medical education to be so tough to crack. I love early learners in the system. I think medical students are so powerful and so passionate, and somehow we put them on this path that like sucks so much of it out of them, and I don't have the energy to try to unpack that right now. I'm just being honest. So I don't know. I mean, I know that I have got like wonderful colleagues and people that have been my mentors along the road who are deeply passionate about medical education. I think that there's a lot of really innovative stuff happening there, but it's too slow, and it is entrenched. And I'm grateful that they're tackling that. That is not my hill today, but I think we got to get there.
So the well care team, what responsibilities do they have whenever they come into the house to report things? Like doctors are supposed to report various things to the Department of Social Services. Mm-hmm. I know that the only thing that people distrust more than the medical field is the foster care system. Mm-hmm. And with the opioid epidemic and crack epidemic, you got a lot of older people who are caring for children, unofficially. So when that well team comes in and they try to come into your house, a lot of people don't want you to come in because you're revealing secrets. What are they responsible for reporting once they come in?
So we're all mandated reporters, which means that if there is any evidence or suspicion even of abuse of a child, of a senior, of a vulnerable person, the teams are mandated to report. That's a very specific use case. I think there is a whole world of gray around, like, life is really hard and complicated, and we're not here to judge you. We're here to support you. And we're here to understand and accompany you. And I do think that individuals have choice. They can invite a city block team member into their home, and they can choose not to for various reasons. So I have not encountered, I think, what you're describing in our model yet. It may happen. I think folks tend to be distrustful for sure, but the way that the teams present themselves is key. And I think really being really clear about what we're here to do. We're here to support you, understand you, work with you, partner and collaborate. And we're here to make sure that everybody's safe. But those two things are very rarely is there's a stark case where we're obliged to report. But everybody understands their obligation if that arises.
This is so, I think your model is so powerful. I'm curious, it seems like where it'll butt up against the hard reality is the financing side. And I'm curious, I'm sure you're thinking about this a lot, sort of how are you envisioning, I'm thinking even like in your clinics where you're working with one insurer, are you able to, people pop in to charge their Wi-Fi? Are other people popping in who are not your patient population? How are you handling that? And how are you kind of envisioning getting to this working within the current payment system in healthcare?
Yeah, so if the current payment system means fee for service, it doesn't work in fee for service. Like this stuff is not, and I don't want us to try to make it work in fee for service. Like if we go down the road of creating CPT codes and billable codes for like, how much time did you spend counseling somebody about how to get enrolled for SNAP? Like we have just totally ruined this moment. I don't think we're going to do that, right? Like the real like tailwinds are around value-based care, is recognizing that we have finite resources, and let's think about the resources in that way. So this is the notion of capitation on an individual patient member basis. And that if we take a hospitalization, take an acute hospitalization, one of the many that a patient like Patty has, and break down what you could do with that money, you could fund like 500 hours of therapy for one hospitalization. And you could avert probably 5 hospitalizations with that, right? You can fund home visits, you can fund social care, you can fund engagement and transportation, and we have to be thinking about it in that way. And so our model is entirely predicated on a value-based environment where we are able to take effectively total cost of care risk, financial risk for outcomes for a population of people that allows us to deploy a care team to support and meet them where they're at and deliver outcomes against that. And so the economics of this are actually, in many ways, the only reason we're able to do this is because of the economic model. For me, it is part of the most joyful thing about this is finally a moment where you can see, you have a clear line of sight into how you can save money and improve outcomes and improve the experience of patients. And like we talk about the triple aim as this sort of like holy grail. I think we like twist ourselves into a pretzel into believing that we can find it everywhere. But here it exists. Like it is very crystal clear. We cannot deliver economic value, economic outcomes for our populations until or unless we meet them. We find our members, we build trust with them, we understand what they need, we help them understand how to get better outcomes, and we influence their behavior. Because ultimately, this is about behavior change. It's about saying, instead of the hospital, call us. It's about saying, when you have the choice between taking your medications today and not, would you take them? It's about saying, if you get that eviction notice in the mail and you are ready to change your address, call us first so we know how to find you. That's behavior change, and that is predicated on trust, and that's predicated on a relationship, and it's predicated on a care team. And it delivers like meaningful economic outcomes when done well.
Hi there. So my question is more so centered around patient empowerment and also environment. So I have a question about, with your current model, do you guys currently endorse improving patient advocacy for themselves so that when they're able to speak about their medical needs, that they feel more empowered to share what's going on with them health-wise and to share their stories? And then my next question is, there's a lot of food deserts, both in New York City and here in North Carolina. So do you currently work with, corner stores and vendors in the New York area to help with providing patients who are with City Block with accessible food and having basic access to food?
Yeah, 2 great questions. The first, absolutely, on sort of empowerment. We do survey our members and on a sort of standard scale on self-efficacy, so an understanding of like their perceived sense of agency and understanding of their health needs. We spent a lot of time on education and on health literacy, also on other financial literacy. Folks have legal issues, like there's a whole bunch of things around that too, but really very much focus on ensuring that people understand what's going on for them and have the tools to make choices, and then are listened to when they make those choices. So that's an absolute strong yes. And actually we found that a lot of the work we do in groups is really helpful there too, where people are, there's a lot of peer learning and exchange that happens there, and support for information dissemination. The question on food is really important. And so the answer to your very specific question is not yet. We are absolutely starting to think about what those partnerships would look like. There are areas that we are currently in North Carolina where having access to healthy food is key at a price point that people can afford. Those are much longer types of partnerships that take to mature, and so we're in conversations and working towards that, but have not launched something yet. We have a small pilot in New York with a CSA and with another organization that provides a food pantry for it's actually lower cost kind of food, groceries, fresh fruits and vegetables that we've been working with them for probably 4 or 5 months now, but have not built a sustained program yet.
Hi, thank you for sharing the amazing work that's happening at City Block. I was wondering if you could share a little bit about the early days as far as structuring this redesign and funding and what that looked like, and if it was grant funded initially or just kind of how you got it up off the ground. My background is coming from working in a number of FQHCs, federally qualified health centers, and trying to do this kind of redesign and not always being very successful, and just so wondering kind of what those, how did it, early days sitting on, tables, scratching it out, and kind of how you really, how it started.
Yeah, no, thanks for asking. So it's when I look back now, I'm like, it's all kind of bonkers to me that I similarly spent time in FQHCs and safety net hospitals and did the thing that you have experienced also, of trying to cobble together funding to do this work, and then looked around to see how this has played out for others too. And I think what we found was that it's really hard to sustain this work through philanthropy, or at best, the sort of corporate social responsibility dollars from large health systems, and that the capital required to stand up this type of a model and to build the technology we wanted to build, and the business model, frankly, that we're hoping to demonstrate at scale, requires that we thought about a much more sustainable and much more significant upfront funding apparatus for this. And so for me, it was a real huge frame shift. But we opted and we decided very intentionally to raise venture capital funding specifically for this. And so we're a for-profit entity, deliberately so, that raised venture funding. We initially were incubated at Alphabet, in one of an Alphabet companies, Sidewalk Labs, and so had a technology background and support there from the very beginning. But I firmly believe that if we believe that this is going to scale, we have to invest in real world economics. We have to invest in thinking about a business that will stand the test, and that allows us to, and holds us accountable, frankly, to being profitable. And so that was a really important tenet for us. It's allowed us to make the investments that we've made early in building the business, and it means that we are accountable to ensuring that we have really clear line of sight to sustainability financially over time. It's been a huge learning shift for me, for sure. One more question.
First, I'm so glad that City Block is in North Carolina. I think this is the right model at the right time. But North Carolina is 70% rural.
Yeah.
How does this model work in rural communities?
Yeah, it's a great question. On the long list of learnings, right? We jokes aside have actually no, it is a joke. We did look into rebranding as Country Roads Health, and we're committed. We're anchored around the people that we need to serve, who need better care and better outcomes, and not anchored around the place in which they receive it. And so part of what has been so exciting for us about North Carolina and actually our second market in Connecticut is similarly not rural yet, but certainly more suburban and less urban than Brooklyn for sure, is that we need to figure out how to do that. And I think the technology piece plays a huge role. States that have significant rural populations have done incredible work using telehealth as a modality. I think there's a way to combine that with that human touch that people really need and crave, as well as with remote modalities. We actually are so committed to this. We built a mobile van that we're driving around the state as another modality with which to deliver care. And so we're figuring it out as they answer. We haven't solved it by any means, but we're committed to learning and to trying and to trying to reach these folks who are further away from hubs, but who deserve and need a better outcome.
Awesome. Dwayne, thanks so much.
Thank you.
Thanks for everybody's attention. If you don't feel inspired from this, then I'm sort of worried about you. And just a few thoughts from me as we close. We're spending plenty of money on healthcare in the country. That's not our problem, which is good. We need to spend it differently. Today, we only spend 7 or 8% of every dollar on primary care. Is there anybody here today that doesn't think we need to pay for primary care differently and to spend more? I know we have to, and that's one of the things I've been committed to with Blue Cross. Finally, I think partnerships and collaboration between health plans and folks like Toy and City Block, our big health systems here in North Carolina, the independents across the state, is really important. We've got to bring health plans closer to the providers of care, and we've got to think about this differently. And we're doing that at Blue Cross North Carolina, and that's one of the reasons I'm here. This is really important. So how we pay for health care and how we work with providers is important. So thank you all for your attention. I think we have another exciting person coming to join this series on January 22nd. So we hope you all will join us then. And thanks so much for your time and attention this morning.